Well, greetings everyone and welcome to the EKG Case of the Week for November 5th, 2012. My name's mobitz at University of Maryland. And before I begin, I just wanted to point one thing out to everybody, and that's my email. So a lot of people have been emailing me and going through the trouble of trying to find my email on our university website, which is probably a hassle. So I provide my email on the first slide. Please email me if you have any questions at all about cases or if you have interesting cases. It's a lot easier to get in touch with me using this email than having to search through our residency website. And again, please feel free to email me about anything or follow me on Twitter. Anyway, let's get on to the EKG case for the week this week. And this was sent to us by Dr. Moshe Simmons, who is an intern at Hadassah Hospital in Mount Scopus, Jerusalem. He's an intern in an internal medicine geriatrics program, which I love to hear because one of my areas of interest is care of the elderly patient in the emergency department. Anyway, this was a fantastic case, a fantastic EKG that he sent to me, and here's the 12-lead EKG. There's a lot of things potentially that are worth discussing on this particular case, and I know we've gone through the 5-step process in the approach to EKGs over the past few weeks. Each of the past few weeks of videos have been somewhat lengthy, and I want to try to keep this short. So I'm going to tell you right up front that most of the findings, as you'll notice up here, most of the findings on this 12-lead EKG are old, but the one new thing is the rhythm. And in fact, one of the reasons that this patient was sent to the emergency department by a primary care physician was because of concerns of rapid atrial fibrillation. And how do you know this is atrial fibrillation? Well, very simple, because the computer is calling this rapid atrial fibrillation with the rate of about 123. So what does that mean? Well, of course, it means it can't be atrial fibrillation because I would never give you a computer interpretation which is correct. So right off the bat, you know that this is a computer interpretation that is incorrect. So let's talk a little bit about the rhythm. We'll blow this up a little bit. And the first question, the main question is this atrial fibrillation? Well, one of the things that you recall about the diagnosis of atrial fibrillation is that the ventricular response has to be irregularly irregular. So this is a very simple take-home point, but it's going to save you in many cases. I promise you, it's burned me in many cases. Atrial fibrillation is the most commonly I don't know if the proper term is being used, but overdiagnosed, misdiagnosed tachydysrhythmia. In other words, we all and the computers have a tendency to overcall incorrectly a lot of rhythms as atrial fibrillation. So whenever you see the computer calling something AFib, or whenever you look at something and see some irregularity and you're tempted to call something atrial fibrillation, stop for a second and ask yourself a very simple question. Is the rhythm truly irregularly irregular? Because true atrial fibrillation should give you an irregular ventricular response. And I'm highlighting this for a reason that you'll see in just a second. Take a good close look at this rhythm. Sure, it is irregular, but if you look carefully, you'll actually notice that it's not exactly irregularly irregular. In fact, what you notice up here is that there's a handful of clumps. Let's say that there's a clump of 2 beats right there, and then another clump of 2 beats, and then there's a clump of 3 beats, and a clump of 2 beats, and there's an isolated PV or isolated ventricular response there, and another clump of 2. Now, is this purely just coincidence that I'm just clumping things like this? Well, again, if you take a good close look, you will notice, get your calipers out. You've got to have calipers. When you get your calipers out, you'll notice that the distance between these 2 beats in the clump is the same as the distance between those 2, which is the same as the distance between those 2, and it also happens to be the same as the distance between those 2 and those 2, and so on. All right? And furthermore, if you separate out the clumps, you'll notice the distance between this clump and this clump. In other words, this distance is the same as this distance, which is the same as this distance, and so on. So this is not irregularly irregular. And therefore, right off the bat, you know that this is not atrial fibrillation. It can't be. It's got to be irregularly irregular. All right? So that's the first thing. Now, let's when you notice clumps, stay away from calling it AFib. Now let's blow up a couple of things. Some of you may have already noticed that it looks like there are some P waves in the rhythm. And what I'm going to do is I'm just going to take a stretch of V1, which, as we've said before, V1 is your money lead. Whenever you're looking for P waves, the first lead to look at is lead V1, not lead 2, which the EKG machine doesn't know any better. It always gives you lead 2. But take a look at lead V1 first, because that oftentimes is the best lead for picking up P waves. And we'll just take a stretch of the V1 rhythm right up there. We'll blow it up, and you'll notice that, sure enough, there are P waves here, right? There's very clearly distinct P waves there. And you'll also notice that there's little bumps right there. Those are P waves as well, right at the end of some of the QRS complexes. So get your calipers again and map those out. And you'll find that if you go from here to here and then continue, there's probably a buried P wave in there. And then it stays very regularly all the way through the entire rhythm. Okay, what that means is that there are actually buried P waves in these abnormal looking QRS complexes. And in fact, if you're asking why are those QRS complexes looking a little bit irregular, it's because there's a fusion between a big QRS that points down and a little P wave that points up. And the result is that the QRS is a little bit wider than the others, and it's a little bit shorter in height or in depth than the other QRS complexes. So, key point, there is a regular atrial rhythm going on here that's going there to there to there to there. You've got to have calipers. Whoop, I kind of screwed that up. There to there, there, and so on. Or, you know what? I keep screwing this up thing. Here we go. Right there. There we go. Okay. So, and again, I'm not using calipers, and that's why I'm screwing it up. So that's your second take-home point. Get calipers and use calipers. If you want to be a pro at rhythms, you've got to have calipers. Okay. And you'll pick up things that you would not normally notice with just your eyes. So now what we're saying is that there are P waves throughout here, and there's some P waves in there as well. Okay. There's P waves in there. And when you see P waves, and it looks like some of these may not be conducted, you need to look at the PR intervals. Whenever you see P waves in QRS complexes, ask yourself, is there association between the P waves and the QRS complexes? How do you know if there's an association? You look at the PR segment. So now we're going to look at the PR segments. That's a pretty long PR segment right there, and that's an even longer PR segment. And if we've assumed that there's a P wave in there, it's not being conducted. There's no QRS complex after that. Then it starts all over again. PR is somewhat long, PR is even longer, and then P wave not being conducted. And then it starts over again. So when the PR segment is getting longer and there's also non-conducted P waves, what does that mean? It means that this is second degree AV block type 1, also known as mobitz 1, or also known as Wenckebach. So what we're looking at is a mobitz 1 rhythm. All right, kind of a cool rhythm, and the machine missed it. The machine overcalled AFib like it always does, and the reason is that the machine saw an irregular ventricular response, but it didn't ask itself, is it irregularly irregular? If it did, the answer is no. It's not irregularly irregular, because again, the distance between these clumps, the beats within the clump, and the distance between the clumps themselves is the same. All right. So this is regularly irregular, and that means that it can't be atrial fibrillation. So very simple take-home points here. AFib is often overdiagnosed. Don't trust your computer. Anytime you or the computer are thinking that this is AFib, stop for a second, get your calipers out, and don't call it AFib unless it truly is an irregularly irregular ventricular response. Oftentimes what you're going to find is that it's actually regularly irregular. And when it is regularly irregular, in other words, there's clumps of beats, that implies that it's mobitz. It could be mobitz 1 or mobitz 2. Here's an example, by the way, of mobitz 2. I just showed you mobitz 1, but notice here's another example of mobitz. This is mobitz 2. There's a clump of 2, and a clump of 2, and a clump of 2, and a clump of 2, okay? So anytime you see clumps, anytime you see something that's regularly irregular, don't call it atrial fibrillation, call it mobitz. And there's, by the way, there's one other thing that gives you clumps, And we're going to talk about that next week. So your differential diagnosis for clumps is mobitz, and stay tuned for next week, all right, for the other thing that gives you clumped beats as well. All right, so simple but fun rhythm case. My thanks to Dr. Simmons for sharing this great case with all of us, and hope that the tough rhythm became very easy once you just break it down. And again, get calipers. You've got to get calipers if you're going to get good at rhythms. All right, hope you all are doing well, and I will talk to you next week. Bye for now.